Assalamu alaikum and very good day everyone, and thank you for joining the breast cancer session. This session will be chaired by Dr. Amna Khan. She is a senior breast surgeon and a well-renowned breast surgeon in Pakistan. So can you please join us? Thank you, Dr. Amna Khan. So our first speaker is Professor Rob Stein. To be very honest, this is my honor to introduce Rob Stein. We used to read his article while during my fellowship, and now he's here with us. He's a professor of breast cancer at University College London. He has an extensive experience as a principal investigator in multi-site phase 2 and phase 3 trials in early as well as advanced breast cancer. And he's also chief investigator for Optima International Trial. He's going to talk about estimating risk of recurrence in early breast cancer. So please welcome Professor Rob Stein. Thank you.
Good morning. Can you hear me? I'm very grateful for the invitation to attend the Shaukat Khanum Cancer Symposium and for the opportunity to share my thoughts about breast cancer prognosis and the risk of recurrence, and also to visit your beautiful city. These are my disclosures. I'm going to start off by talking about prognosis in breast cancer. This is what can currently be achieved in a screened population treated with multidisciplinary care with good access to systemic treatment. And the 10-year survival from disease-free survival is now approaching 85%. Wind the clock back 40 years. This is around the time I started training in oncology. Screening was for the wealthy. There was no multidisciplinary care. Systemic treatment was in its infancy. And round about 50% of women diagnosed with breast cancer would ultimately die from their disease. But who were the 50% who survived? If we can identify those people who were treated sufficiently with surgery alone, it would allow breast cancer professionals to concentrate their efforts on patients with poor prognosis, whilst not exposing patients with a good prognosis to difficult and potentially harmful treatments. This is from a trial that was even older, and it looks at the influence of a number of lymph nodes on survival over a 15-year period. And these were patients who were treated with breast-conserving surgery with surgery and radiotherapy alone. There was no systemic treatment. And it demonstrates very clearly that lymph node involvement predicts for an adverse outcome. That trial and others around the same period demonstrated that to a first approximation at least, lymph node involvement, tumor size, and tumor grade are independent risk factors for recurrence. And it led to the development of a Nottingham Prognostic Index. It's a simple calculation. You can do it in your head in 30 seconds, if that. And it gives you a number. And the graph shows the validation of the Nottingham Prognostic Index in a large group of European patients from multiple hospitals and multiple countries. Patients with a good prognosis label in the green labeled curves do very well, but those who were node positive with large tumors and higher grade tumors do badly. And so we can use the combination of biology and prognosis to predict treatment benefit. So as I've shown you, the combination of stage and biology predict risk, and then you can apply the known benefits of treatment to risk, assuming that all patients have the same proportional benefit from treatment, the so-called proportional hazards model. But biology also predicts treatment sensitivity. So we know that endocrine therapy, HER2-targeted therapy, immunotherapy, in all cases, there are biomarkers that say whether or not tumors are sensitive to those treatment modalities. But there are no proven biomarkers of chemotherapy sensitivity. So this is PREDICT. It's a more modern tool to predict risk and treatment benefit. Rather than using assumptions about the independence of risk factor, it uses registry data, and after allowing for the treatment given to those patients, it then applies trial-based treatment benefits to allow individual risk and treatment benefit estimations. So this illustrates a 54-year-old postmenopausal woman with ER-positive, HER2-negative disease with a 22 millimeter grade 2 tumor and 2 positive lymph nodes. And the survival graph to the right, and also the table, shows that with surgery alone, she has a roughly 74% chance of overall survival over 10 years. But apply endocrine therapy, chemotherapy, and bisphosphonates successively, and you improve that overall survival by 13% in this case to an estimated 87%. And PREDICT is now widely used in the UK and many other countries, including here in Pakistan. This is data from the Oxford Overview, showing that all patients gain the same relative benefit from chemotherapy. And what you are looking at in this table, and you're not meant to be able to read it, but each line shows a prognostic factor. And what you can see is that the hazard ratios all align along that dotted line. There's no variation. So the relative benefit for chemotherapy for all patients is the same. So I'm now going to move on to molecular tools to define prognosis. And it all started here with the intrinsic classification of breast cancer. This is work that began a quarter of a century ago. And what this figure shows are individual tumors. Each column is a tumor, and each row is a gene. And what this looks at is individual gene expression using the then very new technology of microarrays. And tumors in green express a gene at higher level, and those in red express genes at higher level, and those in green at lower levels. And then eliminate genes that don't vary across the population and sort all of those genes, and you can see patterns emerge. And that led to the description of 4 basic biological subtypes of breast cancer with differing prognosis, as shown in the survival curve on the right. This is the intrinsic classification. Well, microarrays are difficult technology. So this was made simpler using PAM50, subsequently commercialized as Prosigna, which is an assay based on the intrinsic classification. And it recreates this intrinsic subtype classification rather than using over 500 genes with just 50 genes. And the tumor risk of recurrence, or Prosigna score, is based on the similarity of test tumor gene expression to each of the PAM50 molecular subtypes. So here you are, this is the tumor you're investigating, and these are the typical profiles of each of the 4 main intrinsic subtypes. And it then adds in a correction factor for proliferation and another for tumor size. And it gives you a score of between 1 and 100 and an intrinsic subtype, the PAM50 intrinsic subtype. And the graph on the right shows that the higher the ROR score, the greater the risk of recurrence over a 10-year period. This is the intrinsic classification now represented by PAM50. This is a group of patients from Canada who received no adjuvant systemic treatment of any description from the 1980s. The blue graph are the so-called luminal A subgroup. The yellow graph is the so-called luminal B subgroup, who do much worse. If you look across large populations and you group tumors by their receptor expression, what you see is that the subtypes cut across receptor expression. So the top left are hormone receptor positive HER2 negative tumors. And 89% of these tumors are either luminal A or luminal B, but 11% are something different. But look at the bottom left. This is the hormone receptor negative HER2 positive tumors. And the bottom right, these are the triple negative tumors, and around about 30% of these are either not HER2 enriched or not basal-like, which are the dominant receptor patterns in those groups, so the dominant subtypes in those groups of tumors. So you can't really accurately say what subtype a patient's tumor belongs to simply from receptor expression. Beyond Prosigna, there are around about 5 tumor gene expression tests or multi-parameter assays in common use. All of them measure different genes, although in all cases, the estrogen receptor and proliferation pathways are strongly represented. All were trained on different populations, but all give you a risk score and a risk category, and in some cases, a subtype. Oncotype DX was the first of these to become commercially available, and it's the most widely used worldwide. It has 16 cancer genes and 5 reference genes measured by RT-PCR. And they're divided into modules: proliferation, estrogen receptor signaling, HER2, invasion, and so on. And each module has a subscore, and then they're combined using this equation on the right. And it's dominated by the HER2 score, the estrogen receptor score group, and the proliferation. And this shows how it works. This is a patient with a recurrence score of 30 who has around about 20% chance of developing distant disease over a 10-year period. And the uncertainty is between about 17.5% and about 22.5%. This is the first randomized validation trial called TAILOR-X. It was performed in node-negative breast cancer, and it took patients with ER-positive, HER2-negative disease who had an Oncotype DX test, and those with a recurrence score of between 11 and 25 were randomized between chemotherapy and endocrine therapy, the conventional treatment, and endocrine therapy alone. And it had a non-inferiority hypothesis. Round about nearly 7,000 patients were analyzed in this trial, and it demonstrated non-inferiority of both invasive disease-free survival, which is recurrence, and distant recurrence. And you can see that in the two graphs at the bottom. The curves are superimposed. The trial population was at low risk. Only about a quarter would be treated with chemotherapy in the UK, and perhaps that represents a difference between UK and US oncology. And because the patients were at low risk, around about 60% of events were unrelated to the primary cancer. And those occurred with equal frequency at the arms, between the arms. But the analysis was done very carefully, and it really controlled for that effect. And I think what it tells you is that Oncotype DX is able to identify patients at sufficiently low risk that they will not benefit from chemotherapy. So predicting chemotherapy sensitivity is a difficult problem. I'm going to sidetrack a bit. This is now talking about prognosis versus prediction. So the patients on the left illustrates prognosis. So the good prognosis group in green do well, and the effect of treatment with the vertical arrow is fairly small, but the patients with poor prognosis do worse, and they gain a much greater absolute benefit from treatment, even though the relative benefit is the same. So think of less versus more lymph node involvement. On the right, you see prediction. So the baseline here is the blue line. And the group of tumors that are insensitive to treatments gain hardly any benefit, which is red. Those that are sensitive to treatment gain a lot of benefit. And again, think of endocrine therapy for estrogen receptor positive versus negative disease. In practice, I can't think of any predictive marker in breast cancer that is not also prognostic. This is now showing how prognosis varies according to nodal status, using, in this case, the ProSigna score. So patients with a ProSigna score of 60 and no lymph node involvement, the blue line at the bottom, have about a 12% chance of developing distant disease. And that's round about the UK lower threshold for chemotherapy use. Patients with 3 involved nodes and a ProSigna score of 60 have double that risk. And to get down to 12% and 3 involved nodes, you need to reduce the ProSigna score to around about 35. So these multi-parameter tests are not very useful in node-positive disease unless they can identify patients with chemotherapy insensitive disease, so they predict chemotherapy sensitivity. And this is the RxPonder trial, which set out to prove that hypothesis. 5,000 patients, both pre and post-menopausal, recruited, relatively old, relatively low-risk patients despite lymph node involvement. About 17% would not be treated with chemotherapy in the UK. and importantly, no requirement for ovarian suppression use for premenopausal patients. The design looks very similar. Indeed, it is, with one important difference, and that is the statistical design was very different. And this shows the results. Premenopausal patients to the left. A convincing benefit for chemotherapy. You can see this two curves are quite well separated. Sorry, this is, but there's potential confounding caused by chemotherapy-induced menopause because those patients treated with endocrine therapy alone were on the whole not given ovarian suppression. The postmenopausal result, the curves lie on top of each other. No difference between trial arms. The result's probably correct, but there is statistical uncertainty because of unrelated events and crossover. So this is the Optima trial, which is what I am mostly known for. It's complicated. It sets out to compare outcome for patients treated using test-directed chemotherapy with standard treatment using a non-inferiority design. So I'll take you through the design very quickly. It recruits high-risk patients, aged at least 40, post-surgery, with ER-positive, HER2-negative disease, and up to 9 involved lymph nodes, and with minimum size requirements for patients with node-negative disease or micrometastases only. The control arm patients are randomized to chemotherapy followed by endocrine therapy, standard treatment. The experimental arm patients have a pro-signa test, and treatment is decided by the score, test-directed chemotherapy. Those with high pro-signa score receive the same treatment as in the control arm. Patients with a low score receive chemotherapy followed by endocrine therapy, and about 2/3 of tumors in the trial are low score. And endocrine therapy includes ovarian function suppression for premenopausal patients. So in practice, all patients with a pro-signa score greater than 60 receive chemotherapy, and patients with lower pro-signa score tumors are in effect randomized between chemotherapy, endocrine therapy, and endocrine therapy alone. The trial is blinded to randomization if you receive chemotherapy, and we do a pro-signa score test for control arm patients to help the analysis, but not for making treatment decisions. And the analysis we won't go through. We don't have any results from the trial, main trial yet, but we have some results from the original feasibility study. So on the left, what you can see is a comparison between oncotype recurrence scores and pro-signa ROR scores for individual tumors. And the large bulk of these are clustered in that bottom left-hand quadrant, group 1. Group 2 has patients with low oncotype scores and high pro-signa scores, so the tests don't agree about these patients. In group 3, the tests agree that the patients have got high score tumors, and finally in group 4, there are hardly any, and they have got low recurrence, low ROR scores, and high oncotype scores. And the characteristics of these patients are shown in the table. And interestingly, there was a predominance in this group of premenopausal women in group 1, and they tend to have lower grade than in the other groups. But other than that, tumor size and nodal involvement is very similar across the 4 groups. And this is the consequence. Just concentrate on groups 1 and 2, labeled in the Kaplan-Meier curve in the left and the bottom 2 quadrants in the 2x2 table on the right. And what this shows is, in effect, pro-signa is able to identify a subgroup of patients with a low oncotype score who have a high risk of recurrence and have poorer outcomes. It's a small group of patients, under 400. We don't know the significance, but it's interesting. The main trial analysis, well, you have to wait until next year. But it's the only trial that includes premenopausal women treated with ovarian function suppression. We won't be able to demonstrate properly that we can avoid chemotherapy in these patients, however, and we need further recruitment to demonstrate non-inferiority in this subgroup. And that's where my collaboration with the Shaukat Khanum, I always get it wrong, Memorial Cancer Center and Research, Memorial Cancer Hospital and Research Center comes from. Apologies. It's the only trial that recruits patients with more than 3 involved nodes. And if patients with 1 to 3 involved nodes and low test score tumors can safely avoid chemotherapy, then that should apply to those with more involved nodes. It's the only trial to include patients treated with 40 CDK4/6 inhibitors and men, and it will provide independent data on test use for postmenopausal patients with 1 to 3 nodes. So, where does that leave us? Well, tumor gene testing, expression testing is expensive. Even a wealthy country like the UK cannot allow unrestricted access. Their use is justified by reduced costs from treatment and from management of its complications and reduced treatment morbidity. But optimizing the selection of patients for testing improves their cost effectiveness. So, there has been one attempt to combine the tests with PREDICT. Unfortunately, it was not very successful. So this shows you data from a clinical trial of endocrine therapy alone, no chemotherapy given. And what it does on the left-hand side, it compares a number of tests with a clinical treatment score based on standard histopathology parameters together with patient age and treatment, endocrine treatment given. And that's in the box here. And the longer the bars, the more information the test provides. And you can see that they're all fairly similar to each other. Now, if you look on the right-hand graph, this one, what's been done is they've taken the effect of a clinical treatment score and then added the test to that. And the extra information provided by the test is shown in blue. And again, what it says is that, at least in this population, the tests can tell you something useful. In node-positive patients, the amount of extra information provided by the test is much smaller, but it's still significant for most of those tests.
We are short of time, Professor Rob.
So there have been a number of attempts to use conventional pathology to identify patients who you don't need to test because they've either got a low score tumor or a good prognosis tumor or a poor prognosis tumor. This is one such example, the so-called Chicago algorithm. What it does is it predicts oncotype DX score. And it uses an artificial intelligence-based approach, but everything does now, to provide that information. And it actually, the validation shows it's pretty good at predicting high oncotype scores, but unfortunately it's not being developed to look at low oncotype scores. And as a general point, there are 3 of these algorithms, and they all need further work. And nobody is hugely interested in this, which is unfortunate because it's very important.
We're running out of time.
Yeah.
Because...
This is my last but one's almost to the end now. I'm sorry, I'm going on. So this is using computational pathology to predict risk, another AI-based tool. And this is now looking at the future. The methods are evolving rapidly. Several computational models have attempted to predict oncotype DX scores, and they've achieved AUC scores of 0.85 to 0.9. It's pretty promising, but it's not good enough. So it leads to a question: can computational pathology actually allow you to avoid expensive tests because it's going to be cheaper? Treatment determined by the computational pathology test. But maybe they aren't going to be quite good enough. Maybe they're not going to make the pathologists redundant. But will they allow us to identify low-risk and high-risk patients with confidence so we can avoid expensive testing, and where we're uncertain, use a secondary gene expression test? There are a lot of problems to be overcome. They're bamboozled. These tests are currently bamboozled by small bits of tumor, by poor fixation, and by poor quality scanning. But all of this, I suspect, will be overcome. And so, as I'm running out of time, I'm not going to go through my summary in detail. This just says what I've said. Thank you very much.
We'll take questions at the end. We'll move on to the next presentation.
Thank you, Professor Ruff, for the excellent talk. So our next speaker is Dr. Azmina Tarjeen Wali Mohammed. She's a consultant medical oncologist working at Aga Khan University Hospital, Karachi. She's going to talk about metastatic HER2 positive breast cancer, how I treat, and she's going to join us virtually. Thank you.
I'm proposing a motion this oncologist at the Khanum Hospital, and I'm allowed to be part of this prestigious symposium, having to share the treatment of HER2-positive metastatic breast cancer. These are my disclosures. HER2-positive breast cancer comprises about 15 to 20% of all cancers, and although this is an aggressive disease, it has this target with an extracellular and an intracellular domain, which gives us the opportunity to target it with different therapies, whether that be an antibody such as trastuzumab, margetuximab, pertuzumab, or an antibody drug conjugate such as the trastuzumab deruxtecan and the trastuzumab emtansine. And then we have the intracellular domain, which can be targeted with small molecules inhibiting the tyrosine kinase activity, such as lapatinib, neratinib, and tucatinib. Since the discovery of HER2 target in the 1980s, various drugs have been approved by the FDA, from trastuzumab in the metastatic, adjuvant, and then neoadjuvant, to lapatinib in the metastatic, pertuzumab in the neoadjuvant and metastatic disease, TDM1 as a second-line treatment, to the Catherine in the post-neoadjuvant residual disease, to ADCs, and to tucatinib in the HER2 decline, and margetuximab. There The outcomes of a patient depends on how we sequence these drugs. From the Cleopatra to the Destiny Breast 03, we have seen that there has been an improvement in the progression-free survival, which is incremental. And this all depends upon the availability of the drugs, upon the tolerance of the patient's desires, and the feasibility. And so the outcomes depend on multiple variables across the different patient population across the world. The most practice-changing trials in the last 13 years have been these. The Cleopatra trial in 2012, getting the approval of pertuzumab with trastuzumab and docetaxel. It showed that there was an improvement in the progression-free survival in patients with as first-line treatment compared to physician's choice treatment. Then we have the Amelia trial in which TDM1 showed the improvement in the outcome in the second-line treatment, as well as HER2-CLIMB, where tucatinib, capecitabine, and trastuzumab was given to patients either as a second-line or a third-line, particularly in patients who had active or treated brain mets. And then we saw Destiny 03, where T-DXd, trastuzumab deruxtecan, was compared to TDM1, and it showed that there was a discernible improvement in the outcome of these patients. So when one sees the K graphs of the Cleopatra and the Destiny in the second-line treatment, we see the outcomes are far better than the Cleopatra in the first line. And this requires that these drugs should be tested in the first line setting. And this is exactly what was addressed and discussed in the interim analysis of the Destiny Breast 09 trial by Dr. Sarah Tolani from Dana-Farber at the ASCO 2025 Congress this year, where trastuzumab deruxtecan, along with pertuzumab, was compared with taxane, trastuzumab, and pertuzumab for the first-line treatment of patients with HER2-positive advanced metastatic breast cancer. Now, this is an interim analysis of this trial. The rationale for combining pertuzumab with T-DXd was to ensure that there was a complete and a durable blockade of the HER2 receptor. How T-DXd has evolved has been interesting because we have seen third-line treatment. We have seen it move from the third-line treatment of patients, imparting almost an 11-month improvement in the progression-free survival in the third-line treatment to a 22-month improvement in the PFS in the Destiny Breast 03. And now we are going to compare how it fares compared to the Cleopatra in the first-line trial. So in this randomized trial of first-line metastatic disease, allowing patients with brain mets to be included, patients were allowed to have targeted therapy or trastuzumab and pertuzumab only in the adjuvant or the neoadjuvant trial setting. The disease-free interval was more than 6 months from the last chemotherapy, and 1 prior line of endocrine therapy was allowed. Patient was randomized 1:1:1 into 3 arms, consisting of T-DXd, T-DXd plus pertuzumab, and the Cleopatra DHP trial. Endpoints, primary endpoints were PFS. The key secondary endpoints were the overall survival of these patients. At the planned interim analysis, with the data cutoff for February 26, 2025, the results have been reported for T-DXd plus pertuzumab with DHP. The T-DXd plus the T-DXd plus placebo arm remains blinded and will be discussed in the next few days. The final overall survival analysis will also be conducted. When we look at the patient demographics, 50% of the patients were Asian, as this was a global trial. 25% patients were from US and Europe, and the rest of the world. Most patients had HER2 plus 3 disease, and the rest had HER2 plus 2 or less than 3, which were positive on FISH. 30% of the patient had PI3 kinase mutations, and about 75% of the patients had visceral disease. Prior therapies consisting of HER2-targeted therapy was only allowed in the neoadjuvant or the adjuvant setting. Endocrine therapy was given in 1/5 of the patients. When we look at the progression-free survival, which was the primary endpoint, the curves separate early and they continue to separate and widen with time, with 12% of the patients on the THP progressing versus half the number on the TDXT. So the median progression-free survival was 41 months versus 27 months, with the delta of 13.8 months and with a hazard ratio of 0.56 with a significant p-value. The same outcomes with a delta of 20 months was reported by the investigator-assessed PFS. So this was a clinically meaningful improvement in PFS with the TDXT plus pertuzumab versus THP. Benefit was seen across all subgroup of patients, including those patients who were stratified by de novo or recurrent disease, hormone receptor status, and the PI3 kinase mutations. Overall response was also numerically higher in these patients, 85% versus 78.6%. The complete response rate was also double that of the THP, and the duration of response was also substantially longer, with 73% of the patients remaining in response versus 54.9% of the patients. So this was something which was significant statistically. The overall survival, only there is a 16% maturity level, but this was seen to have, it shows a trend towards an improvement and favoring the combination arm. Side effects of TDXT that need special attention are the GI side effects, which requires a very strong antiemetic treatment. Lung inflammation is seen in about 10 to 15% of the patients, and this is in terms of the effect of ILD or pneumonitis, which requires that patients have a regular CT scan of the lungs. And in this study, the scanning was done at 8 to 10 week interval. Attention is paid to the minutest of the symptoms. So the patients who has cough or shortness of breath requires an HRCT. The drug needs to be stopped early on. There are guidelines which tell you about the grades of the drugs, of the toxicity, and the side effect management with the different steroid protocol. So when we compare the treatment adverse effects of the combination TDXT versus the THP arm, we see that there's a far more chance of having nausea with this drug. The diarrhea rate is almost the same, so is the neutropenia. Fatigue is a little more. These patients, despite of having an antibody drug conjugate, do have alopecia, so that needs to be also addressed. And then, of course, there are transaminase elevations and blood counts, which need to be monitored equally as well in this situation. The adverse effect of special interest is pneumonitis, and it is seen in about 12% of the patients. Sorry, I can't seem to go back to the slide. Just to state that the adverse effects of ILD are seen in about 12% of the patients, and about 2% patients had grade 5 toxicity. Most of the toxicity was of the grade 1 and grade 2. The other side effect is a decline in the LV function, and which was seen in about 11% of the patients with the TDXT pertuzumab versus 7% in the THP arm. So to conclude, if you look at the progression-free survival, there is a 44% reduction in the risk of disease progression or death with the combination versus THP. thus demonstrating a statistically significant and clinically meaningful improvement, which may represent the new first-line standard of care for patients with advanced HER2-positive breast cancer. Around 30 to 50% of our patients develop brain metastases, and it becomes a challenge to control this disease, especially in the brain, which is a sanctuary site. And we have studies comprising of small molecules tucatinib in the HER2 climb, which shows benefit both in patients with active disease and treated metastases. But when they progress on this treatment also, or if they have stable disease in the rest of the body and there's no evidence of systemic disease, what do you do in these patients? So this particular study looking at T-DXd in patients with baseline brain metastases, either stable disease or active brain disease, which is untreated or previously treated and not progressing on, not requiring immediate local therapy such as radiation, were given T-DXd Q3 weekly, and the primary endpoint was progression-free survival. And we look at the progression-free survival, it shows promising improvement of 17 months in terms of the PFS. And also this waterfall graph shows a deep and a significant number of patients getting benefit out of these drugs. So we know T-DXd has shown its benefit in the second line and the first line, but this is an early escalation, especially in low middle income countries. And the question is, should it be given to everyone? Can we look at other markers of response in these patients to be more selective for the choice of treatment in them? So who are these patients who have early progression? We all know that we have patients who have both in the DESTINY-Breast09, about 27% of the patients who have an early progression, and also in the Cleopatra trial. And what we're trying to do is we're trying to prolong their life with the selection of the most sustainable, economically feasible, appropriate treatment with the least side effects. So if T-DXd is administered as the first-line treatment in patients with hormone receptor positive disease, what would be the maintenance treatment? And if it is administered as a first-line treatment in a patient who had hormone receptor negative HER2 positive, what would be the maintenance treatment? So can we select these patients with early progression, or those patients who have a long stretched out survival, to customize the treatment according to those unique markers? Looking at PI3 kinase mutation in response to THP in the Cleopatra, when we look at the solid blue and the yellow, which represents the PI3 mutation, and even with the dual targeted therapy, they do poorly. So if we could identify these patients who are going to do poorly based on their biomarker, especially the PIK3 mutation, we could perhaps modify the treatment and escalate the treatment to more like a antibody drug conjugate T-DXd. And we also have patients who do well for many, many years. And these are patients who have prolonged survival. These patients have oligometastatic disease, who have indolent disease, who have no visceral metastases. And so these are the patients, 16% of the patients who will have a very good outcome, and they're progression-free even at 8 years. Now, the results of the HER2-DX assay, which is a genomic microassay, which was performed in the Cleopatra trial, showed that we can identify these patients based on the HER2-DX assay, which is graded as high, medium, and low. And then we can customize treatment. Patients with low score do poorly, and perhaps they would do well with change and modification of their treatment. So can we optimize the Cleopatra strategy? And there are patients who are triple positive, and these patients do well. And can we optimize the endocrine therapy in these patients? So this is exactly what was addressed in the Patina trial with patients who had hormone receptor positive, who were given THP, who completed the treatment, and they had stable disease. They were moved on to a maintenance therapy with trastuzumab, endocrine therapy, letrozole, and palbociclib versus trastuzumab and letrozole alone. And when we look at outcome in these patients, we see that there is an improvement in the progression-free survival, which is 44 months versus 29 months in the dual targeted therapy versus the CDK4/6 inhibitor addition. So this is something which is certainly evolved into our practices, and we are considering for some patients TDXT as first-line treatment, and for some patients we are using we are using the Patina-like regimen. So how do we integrate these data in our treatment algorithm? How do we sequence them optimally? What clinical parameters do we use? Do we use patients with heavy burden disease, patients who have short disease-free interval, patients who have shown poor response to neoadjuvant therapy, patients who have brain metastases, to select them for TDXT therapy as a first line? Do we use biological markers such as the PIK3CA mutation, which if seen in 30% of patients, to select them for TDXT? Or we use a HER2-DX assay or a dynamic treatment response marker such as the ctDNA levels to see how these patients are doing and if they're clearing the circulating DNA from the system. And of course, the patient factors are paramount in all this. The choice of the drug, the availability of the drug, the socioeconomic feasibility, everything has to be kept in mind. The duration of treatment is something which is also needs to be addressed. And in the Destiny Breast 09, TDXT was continued until progression of disease, which may not be feasible. So can we give an induction therapy followed by a maintenance therapy and get the same outcomes of patients who have hormone receptor positive disease? Can we just give them THP and then give them a Patina-like regimen? So these are things to be looked at and answered in the future. And beyond TDXT, if we administer TDXT as the first-line treatment for patients with triple-negative positive disease, what would be the maintenance therapy? If TDXT is administered as the first-line treatment for hormone receptor, what would be the maintenance? And if the patients progressed, what would be the most appropriate targeted therapy for these patients? There are many more HER2 ADCs which are currently in development, and they are looking at different targets besides the HER2 target. So the TROP2 is being explored. The linker technology has been modified to make it more and more effective intracellularly, and the payload has been modified so that it's not only an effective payload, but it also has a bystander effect. So to summarize, there are many treatment options that are available for HER2-positive metastatic breast cancer. The sequence from one treatment to the next will depend on the disease control, tolerability, and the availability of the medications. Symptom management, side effects, monitoring, and quality of life are integral to the treatment of metastatic disease. Thank you very much.
Thank you, Dr. Azmina. So our last speaker for this session is Dr. Kamran Rashid. He is consultant medical oncologist at Rashid Nursing Home and Cancer Center. I think he's a jack of all trades. He treats multiple sites of cancer. So to be very honest, I'm really inspired of him. So he's going to, and he's also president-elect of Society of Medical Oncology of Pakistan. So he's going to talk about how I treat triple-negative breast cancer in 2025. Welcome.
Thank you very much. It's a great honor to be here and presenting this prestigious place. So I'm going to talk about is how not now how I treat triple negative, how triple negative breast cancer should be treated, right? That's a better way of putting it. So just few facts about triple negative breast cancer, that it's not very common. 10 to 15% of cancers will be triple negative breast cancer, and it's an aggressive subtype. And 15% of metastatic breast cancer, triple negative, will survive after 5 years after diagnosis, compared to the ER/PR positive. They have a very high incidence of survival up to 5 years. And they are basically 60% of these tumors are PD-L1 negative. And the real important point in treating triple negative breast cancer, I just put that in a bold letters, that approximately 50% of these patients with aggressive disease do not receive a second line treatment. This is very, very dramatic. Like we talked about the lung cancer, one treatment after another. 50%, half of these patients will not get a second chance. So you really, really have to be mindful in treating these patients. You may not get a second chance with these patients. These are some of the algorithms of how to treat these patients, the ESMO, as well as on the NCCN guidelines. So I just want to start with these algorithms, that how to start with a triple negative breast cancer. What should be your thought process? So the first thing you will see is it's a PD-L1 testing, and the BRCA testing. I'll show you some studies that why it's important to check the PD-L1, because the first line treatment will change if they're PD-L1 positive versus PD-L1 negative based on these studies. So these are the three studies, the Impassion 130, Impassion 131, and the Keynote 355. I will just talk about 355, which has become the standard of care. These are all studies which showed, especially in the Keynote 355, showed when the CPS score with the DECO 2 to 3C was more than 10, these patients were offered immunotherapy. This is the paper which was published, New England Journal of Medicine, and it showed that head-to-head there was a comparison between pembro with chemotherapy versus placebo with chemotherapy, and the treatment was continued till disease progression, and this was the overall survival, that the arm which got pembro with chemotherapy, the 23-month survival benefit versus 16.1 month, which was statistically significant. And what I want to show you is that all types of chemotherapies benefited. The previous Impassion studies with Tecentriq, initially nab-paclitaxel was used, and there was a PFS advantage. But when they used weekly paclitaxel, that advantage went away. So in the UK, if you have to use atezolizumab in triple negative breast cancer, the only partner which is approved is nab-paclitaxel. But in Keynote 522, you can use nab-paclitaxel, gem-carbo, and you can see that all the hazard ratios were in favor of any kind of partner can be used in the chemotherapy arm. And how about this is actually now we have this immunotherapy being used in neoadjuvant setting in Keynote 522, because a lot of these patients will get immunotherapy pembro upfront. What to do with them? So this is a study done by Dr. Rebecca Den, that if these patients relapse earlier on, within less than 12 months after finishing their chemotherapy, do they benefit by adding immunotherapy? And this is the Impassion 132 study, and it did not show any benefit in, even if they are PD-L1 positive. In this, again, the immunotherapy used was atezolizumab compared to regular chemotherapy, and there was no benefit. So if the patient gets chemotherapy in an adjuvant setting and relapses very quickly, then the benefit of immunotherapy is not there. Now, the next test, if they're PD-L1 negative, then the next test need to check is the BRCA mutation 1 and 2 in these patients, because the PARP inhibition has become the standard of care in metastatic triple negative breast cancer. And based on these two studies, Olympia trial and Embarcus study, and what they showed was that olaparib, which is a PARP inhibitor, and talazoparib, which is another PARP inhibitor, was compared to the standard of care chemotherapy. But none of these studies used carboplatin as the comparator arm in chemotherapy, because we know these triple negatives, which are BRCA mutated, are very sensitive to platinums. And what they showed in these studies was that there was a PFS advantage, overall survival advantage. The overall relapse response rate was 60% in just with a single pill, just few pills, and these patients responded very well. And the duration of response was 6.4 months and 5.4 months in both these studies if you have a BRCA mutation. Now, what's new? So for these BRCA, we do germline mutation, right? We check it from the blood. But now this is again a study from Tang, which showed that patients who have PAL-B germline mutation, they also benefit from. There is some data which is coming out, and also patients having somatic mutations of BRCA1 and 2. That is in the tissue, they have BRCA. You do a next generation sequencing in these patients, and the tissue shows BRCA1 and 2 mutation. They also benefited from these PARP inhibitors, but there was no benefit of patients having ATM or CHEK2 mutations. This is another newer PARP inhibitor known as suraparib, which is also being worked on with lesser side effects. They've shown that it's a little more effective. Now, another big thing in the management of triple negative metastatic breast cancer is ADC, antibody drug conjugates, which Dr. Azmina talked briefly about. And most of the triple negative breast cancers express TROP2 receptors. And these are the three ADCs, which are, some of them are approved and some of them are in trials. So the main are sacituzumab, govitecan, so datopotamab, deruxtecan, and sacituzumab, trimutican. So the concept of ADCs are they have a binding site, and then they have a linker with a payload. And the payload in all these ADCs are topoisomerase 1 inhibitor. In this case, it's SN38. In this, it is DXD. And in this one, this is balotican derivative, topoisomerase inhibitor. And what happens is these linker, they are sensitive. Once they go into the cell, the linker breaks down, and the payload is delivered to the cell, to the TROP2 positive cells. These are some of the pharmacokinetics. Just want to highlight that sacituzumab has a shorter half-life compared to datopotamab, which has a 5-day half-life. So dosing is different. In saci, you give day 1 and day 8, whereas datopotamab is given once every 21 days, and saci TMT is given day 1 and day 15. It is a 57-hour half-life. Now, this is the first study known as the ASCENT trial, which is a phase 3 trial by Dr. Bardia in triple negative breast cancer. And this is the trial design that patients who have received more than 2 lines of chemotherapy, just like in any malignancy, we try these drugs later on. And once we see their advantage, we move them in the front line. And they compared sacituzumab govitecan with the treatment of choice, physician choice chemotherapy. And it was continued under disease progression. Primary endpoint was PFS. Secondary was overall survival, response rate, duration of response, safety. And what they showed in this trial was the arm which got sacituzumab. There's a 4.8 month PFS versus 1.7 months. The overall survival was 11.8 months versus 6.9 months. So based on this trial, the drug was approved for patients who have failed 2 lines of chemotherapy in a metastatic triple negative disease. This is based on the TROP2 expression. So all the subsets, whether you have low TROP2 expression or a higher, if you have a higher, the response rates are slightly better. Overall survival is the same. Now, this led to the use of this drug in the frontline setting. So how about we use it in the frontline setting? So this paper was recently published in New England Journal of Medicine, October 19, just a few weeks ago. And this is the ASCENT-3 trial, in which they used, this is the trial design, that patients who were previously untreated and they were metastatic, locally advanced triple negative breast cancer patients, randomized 1:1 with sacituzumab govitecan or with a physician's choice of chemotherapy. And they were continued on this drug, progressed, and the primary endpoint was PFS, overall survival, safety, duration of response for the secondary endpoints. And this is from that paper that the progression-free survival was in the favor of sacituzumab, 9.7 month versus chemotherapy, which was 6.9 month. Even more interesting is the duration of response. It's almost doubled. Sacituzumab govitecan is 12.2 months versus 7.2 months. And these are some of the other parameters which they are following. It's too early, overall survival, objective response there. They're pretty much comparable now, but most probably with time, we will get the real picture. And these are some of the adverse effects in which they compared in the paper. They also gave a subset analysis. All the subsets benefited from this ADC. This was the press release after that, based on this PFS, this drug may get approved in the frontline setting, and the overall survival is still awaited. It will take a few years for them to report the overall survival. Now, how about the other ADC, datopotamab deruxtecan? This is actually a pan-tumor study in which it was tried in all different tumors, and this is the data from in those pan-tumor, the breast patients, and you can see the waterfall plot, how they responded. These are actually two studies going on with this ADC, the Tropion-Breast02 and the Tropion-Breast05. Tropion-Breast02 is just the Dato-DXd monotherapy in the second line or in the third line with the standard chemotherapy. This was just reported at this ESMO in Berlin. And this trial was positive. The PFS was almost doubled compared to the chemotherapy arm. And similarly, Tropion-Breast05, these are for the PD-L1 negative or not assessed. And this is for the PD-L1 positive, combining Dato with Durvalumab. So, this trial is also going on, not reported up till yet. Now, this is the third SAC-TMT, the third ADC. Initially, these trials were done in China, but now a US company has acquired this drug, and they're doing trials in US now. So this is the OptiTrop trial. Again, just like a SENT trial, in more than 2 lines of chemotherapy, SACI-TMT was combined with patient's choice chemotherapy, and it was continued until disease progression. Primary endpoint was PFS, secondary endpoint overall survival, duration of response, PFS by investigator dependent. And what they showed was, again, there was a PFS advantage as well as overall survival advantage. And they did a phase 2 trial doing it frontline, moving it in the frontline, and but it was a phase 2 trial. So this trial was also positive. So most probably a phase 3 trial in the frontline is being done in US right now. Now, the third one, Destiny, just Dr. Azmina talked about the Destiny studies. Also, the data is stronger in HER2-neu positive disease, which are HER2-neu negative, ERPR positive. In the triple negative, the Destiny Breast04 had some patients which were triple negative, right? And this is the data of those patients, head-to-head comparison with chemotherapy. And what they showed was there was a survival advantage, there was a PFS advantage in the TDXT arm and overall survival advantage. Though this antibody is still, ADC is still not the standard of care in the triple negative because there's not a clean trial. This was just a subset analysis in that trial. Now, there are some other targets. We just talked about the TROP2 targets. There are the Nectin-4 target and enfortumab vedotin. We do it in bladder cancer, urothelial carcinomas, HER3, B7H4, LIV. So these are few new targets against which ADCs are being developed. And, because once these ADCs get used up upfront, how do we sequence them? What do we do once they progress on those ADCs? What is next after that? So, once these drugs get approved, then second line, third line, things will show up. Now, how about combining? So we have data, ASCENT-3 has shown that we can start it upfront instead of waiting as a second or a third line. Now, what about those patients who are PD-L1 positive? How about combining ADC with immunotherapy, right? So there is some preclinical data like Begonia study in which Dato-DXd with Durvalumab was tried, and they showed overall response rate of 79%. Similarly, Morpheus trial in which govitecan plus atezolizumab were combined together. These were both PD-L1 positive patients, and overall response rate was 77%. So this led to this trial, which was presented June 2025 in ASCO. And this was one of the plenary sessions in which they showed the ASCENT-04 trial. In that trial, they showed was that there was previously untreated, locally advanced, unresectable, or metastatic triple-negative breast cancer patients who were PD-L1 positive. CPS score was more than 10. And they had more than 6 months since treatment in curative setting. And they were randomized 1:1 to sacituzumab plus Pembro versus chemotherapy plus Pembro, which is the standard of care based on Keynote 355. And these all treatments, including Saci plus chemo, were continued until the investigator verified disease progression or unacceptable toxicity. Again, the primary endpoint was PFS, secondary endpoint was overall survival, response rate, duration of response, safety, quality of life. And again, this data, this is the progression-free survival from that Keynote 04 study. The SESI plus Pembro arm showed the survival of around 11.2 months versus 7.8 months in the frontline setting. And again, this is the PFS with a subgroup analysis of the forest plot. You can see different subgroups shown, and most of these, all the subgroups, they benefited from sacituzumab with plus pembrolizumab. These are the side effect profile, chemotherapy Pembro plus Sesi plus Pembro, and it's pretty much comparable. You won't see, there's not much of a difference between the two regimens. Now, just summarizing several phase 3 trials, which will change the way we manage these patients in the coming few months. So, ASCENTO-3 trial, we talked about SESI in the frontline setting. It has been reported. I showed you the data that SESI govitecan was better than standard chemotherapy. The TROPION-Breast02 presented at this ESMO. Also, again, datopotamab deruxtecan in the frontline setting was better than the standard chemotherapy. These are the two other trials going on. Then these are for the PD-L1 negative patients. How about PD-L1 positive population? The ASCENTO-4 trial, which was just presented at the ASCO 2025. Sacituzumab plus Pembro was better than chemo plus Pembro. And this TROPION-Breast05 trial is going on, and they have not reported this trial. So how I treat now, what will be the roadmap after the data I presented? So if somebody has a triple negative metastatic breast cancer, the first test we should check is the PD-L1 testing, the DECO-2-C3 test. And if they are more than 12 months from adjuvant treatment or de novo metastatic triple-negative breast cancer, based on Keynote 355, the standard has been giving Pembro plus Pacli or nab-pacli. If they're less than 3 months, you can give Pembro plus Gem-Carbo based on Keynote 355. If they're PD-L1 negative and they are BRCA mutated, PARP inhibitors should be offered to these patients based on the Lumpiad and Embraca trial. But if they are PD-L1 negative and BRCA wild type, they should be offered simple Pacli, nab-pacli, or Gem-Carbo based chemotherapy. Now, what happens once they progress? The second line ASCENT trial based on ASCENT phase 3 trial, sacituzumab govitecan is the standard of care. And again, Destiny Presto-4 with a HER2 neu low triple negative, that's another option. And then PARP inhibitors, if germline or PARP or PAL-B or somatic mutations are found, then this can be considered. Now, what has changed with these newer trials? One options are, and then after second line option not previously used, you can try chemotherapy. Now, what will change is that, again, based on the ASCENTO-4 trial, these sacituzumab and Pembro, if they're PD-L1 positive, it will be moved in the frontline setting. So we will not have Pembro plus chemotherapy. Most probably down the road in the coming few months, ASCENTO-4 will become the standard of care for these triple negative breast cancer patients. And similarly for patients who are PD-L1 negative and BRCA negative, for them, chemotherapy will not be the standard of care. For them, based on the ASCENTO-3 trial, there will be sacituzumab govitecan and TROPION-2, which was just presented in this ESMO. Dato-DXd will become the frontline standard of care. So I believe the standard of care will change very quickly in these triple negative breast cancers. So that was my last slide. I'm before time. I've saved time. Thank you.
Thank you, Dr. Kamal. Professor Rob, can you join us for question and answer session? So any question from the audience? So Professor Rob, I have a question for you. You presented Optima Prelim 10-year follow-up result at ESMO recently. So can you please summarize that result for us? I would appreciate the Optima Prelim result you presented at ESMO.
Yes. You hear me? Yes. Okay. Sorry, the question?
So you presented the Optima Prelim result 10-year follow-ups at ESMO this year. Can you please summarize that results for us? Can you please give us some summary of that results?
Yeah, so Optima Prelim was a small group of
Yeah.
patients.
Yeah.
I think 412 were recruited. We never intended to analyze this independently. It was going to be part of the main trial analysis, but it turned out in 2024, when we did the interim analysis, that we didn't actually need to analyze the two together, so we could have the main trial, a much cleaner group with treatment decided by Prosigna, and the small Optima Prelim group with treatments decided by Oncotype DX. Within that limitation that it was very small, we didn't see any difference between the trial arms, but it's not significant. It's far too small.
Okay.
And so they just look the same. That's all we can say.
Right. So, Dr. Kaman, so you presented the metastatic setting, but I would be interested in somewhat in early setting. To be very honest, I'm quite scared about the carboplatin. So what is your cutoff level for the tumor size? Where do you add carboplatin? Is it 2 centimeter or above, or is it anything else? And what is your experience with carboplatin?
In the neoadjuvant setting?
Yeah.
Yeah, it's more than 2 centimeter. If it's more than 2 centimeter, I like adding carboplatin.
Because
If it's a node positive disease, or if it's a node positive disease.
I am always very scared of the residual disease. Once Professor Rob, I was talking to him, he told me that residual disease is always dangerous. It is always very, very, we should try our best to. So you have cut off of 2
2
centimeter.
or node positivity.
Okay. And irrespective of node status, if there is not positivity. And what?
Either more than 2 centimeter, or they are node positive.
And which one do you prefer, 3-weekly or weekly carboplatin?
It
Because
depends. Usually, I do 3-weekly. Keynote 522 did every 3 weeks carboplatin.
this year at ESMO, there was a very interesting trial presented from Tata Memorial. I think they shows that weekly. I use 3-weekly as you do, but they have shown that 3-weekly carboplatin in a neoadjuvant setting has OS benefit as well, which was quite impressive. So
if the patient is frail, you think patient will not tolerate every 3-week dose, I then break it down to weekly dosing. But if patient is young, usually triple negatives are young patients, they're fitter patients. So in the neoadjuvant setting, I usually give them every 3 weeks.
So one more question from the Professor Rob. So you as you mentioned, the Nottingham NPI, Nottingham Prognostic Index, and the breast predict. Unfortunately, we don't have access to multiparametric assays in low middle income countries. So which one do you prefer, and which do you think that can be considered for the treatment decision? Is it NPI or predict best?
I think you should use predict.
Predict. Okay.
I think it's better. It has, so NPI is very simple, and that makes it very easy. The problem with predict is that it's based on UK registry data, and so it may give you a falsely good impression if your patients are not screened, and so you don't have early detection. And I don't know if you've ever looked at Predict version 3. The data I showed you was from Predict version 2, but from Predict version 3, which is based on much more recent registry data, the prognosis is actually exceptionally good for all patients and has led to a lot of controversy. It's not generally used in the UK because people just don't believe it.
Okay, right. Thank you. So I think we have some time, but we will just wind up this session because we have to go for the Juma prayer. So thank you very much. Thank you everyone for joining us. Thank you.